find that.
I think.
Here, and there's more than you know, is that
this is because Professor Chen mentioned that previously we do have sort of the regular meeting for all the fellows. And this education previously was mainly teaching OGS. We will ask each of you to present every time, and then maybe 10 minutes presentation and another 10 minutes asking questions, and then maybe another 10 minutes for discussion and talking about the tool here. What is our opinion about so it's a kind of free informal meeting so that everybody enjoys the talk over that academic knowledge and change.
Sometimes you are on the centers, you do have some experience, then you can share your own experience. If you can that you share with us health experience or comment on the experiments or things that you and share or any type of maybe a problem of difficult or anything that you want to do more detail. Ask for the teammates that are here. So well in charge of the scheduling of the month.
That's fine. Will you come sit in front? So today, we invited our chief resident, Dr. Lin Chongkai, will present a topic related to the bone graft in craniofacial surgery. I think from next on, probably in March, Hinton and me will arrange a schedule of all our fellow friends to come present here every Monday morning around 8 a.m. to 8:45 before the first schedule in operating room. Okay, so the schedule will come soon. So Dr. Lin, please.
Good morning. The article I'm presenting today is to compare two different techniques on the alveolar ridge augmentation. The onlay block bone grafts is to correct intermaxillary relationships and to achieve an adequate bone and in terms of volume and morphology. And autologous bone graft is currently the best bone substitute due to its biological properties. And harvesting intraoral donor areas for treatment of alveolar bone defects of the partial edentulous patients has been justified in previous literature. However, an important problem of the onlay graft is the high incidence of bone resorption, which is quite important in vertical augmentation as the force exerts of the graft. So the vertical augmentation still remains the most challenging procedure for doctors. And the reason being includes that the lower source of osteogenic cells, less vascularization, and difficulty in doing primary closure with a risk of wound dehiscence. And up to 41.5% of bone loss of onlay grafts is obtained in the first 6 months, is reported in several literatures. And the process of graft neovascularization after fixation in the recipient area is important for its long-term viability. And the revascularization, which has to be fast and complete, is pretty much difficult to occur entirely in the case of bone blocks with a large cortical component, like onlay grafts. And it has been described that before the vessel neovascularization reached the interior of the graft, the central areas are necrotic already, and which eventually resulted in their subsequent resorption. And the cortical tenting technique consists of a thin lamina cortical block tented over the particulate material. And in this technique, the structure combines an outer layer of the thin cortical bone doing an autologous biological membrane, and which provides consistency while allowing vascular penetration into the inside of the particulate bone, which could favor a rapid revascularization and less resorption. And screwing the bone block at a certain distance from the alveolar crest may lead to high bone augmentation, unlike the onlay graft, in which the increase is limited by the width of the block harvested. So the hypothesis of the study was the cortical tenting technique can achieve better bone gain and less graft resorption comparing to the onlay grafts in patients with bone atrophy of the alveolar ridge. The aim of the study is to systematically review that in patients with localized alveolar ridge defects who underwent a bone augmentation procedure with intraoral autogenous block bone grafts, will the cortical tenting technique of the onlay bone grafts have better outcome or not? And the study will assess the bone gain and resorption, and then look at the complications of the two different techniques. For the method, the focus questions is an adaptation of the PICO structured question, which is compared of PEO, population, exposition, and the outcome. And this PEO approach is adequate for performing qualitative systematic reviews in health interventions. So the population of the study will be the edentaless patients with atrophic alveolar ridges, and the exposition is only grafts and cortical tenting technique augmentation. The outcome, outcome 1 will be the bone gain and resorption rate, and outcome 2 will be the post-op complications related to the bone graft augmentation. And outcome 3 will be the survival and success implant rates and the peri-implant marginal bone loss. And the articles were included in the systemic review if they met the following inclusion criteria. Okay. The study design included the randomized clinical trials, prospective, retrospective studies, and studies on humans in more than 5 patients. And patients with atrophic ridges treated with intraoral autogenous block bone grafts were also included. And the intervention includes the onlay bone grafts or cortical tenting techniques with a minimal follow-up of 6 months. And the outcomes includes that studies includes the bone gain or the resorption rate as the main variable. And the results. And a total of 102 articles were obtained from the initial screening process. Of these publications, 31 studies were identified as potentially eligible articles through screening by titles and abstracts. And as a result, 18 articles fulfilled the inclusion criteria and were finally included in the present systemic review. Of the 18 included studies, 4 of them were randomized clinical trials. And a total of 470 patients and 581 sites were treated, including 237 patients for cortical tenting and 233 patients for onlay bone grafts. And these are all the studies listed in this systematic review. And for the randomized studies, a high risk of bias of the systematic review was considered after examination. And for the non-randomized observational studies, the risk of bias were considered low in the 4 studies and high in the other 7 studies. For the results of the bone gain and superficial bone resorption, looking at the onlay block bone grafts, vertical bone gain mean was 4.24 millimeter, and the mean superficial resorption rate was 20%. For studies that non-membrane was used, the horizontal bone gain was 4.29 millimeter, and the superficial resorption rate was 10%. Looking at the cortical tenting technique, okay, vertical bone gain mean was 6.17 millimeter, and the superficial resorption rate was about 10%. For complications related to bone grafting, only onlay grafts has 30 complications from 202 grafting sites in 10 studies, and the cortical tending technique has 63 complications from 193 grafting sites in 6 studies. And these are all the studies that listed the post-op complications. And the most frequent complication in onlay group was wound dehiscence with an early member exposure or graft exposure. And for the cortical tenting technique, the most frequent complication was also wound dehiscence, following by a screw exposure and graft loss and infection. And chin hypoplasia, chin hypoesthesia was the most frequent complication of the donor area in the both groups. Looking at the implant survival and success rates and peri-implant marginal bone loss, the onlay group has 100% of survival rate, 92% of success rate. And for peri-implant marginal bone loss, 1.26 millimeter at a seven-year post-loading. And looking at the cortical tenting technique group, 96% of survival rate, 100% of success rate, and 0.77 millimeter of peri-implant marginal bone loss at a 48 to 84 months post-op. For the discussion part, the present systemic review explains the bone gain, superficial resorption, and post-op complication rates and the outcomes of the implant from the onlay bone block graft versus the cortical tenting technique, and the lack of the randomized studies comparing the both techniques, making it impossible to do a meta-analysis. So in this paper, the outcomes were shown in a descriptive way for the two groups. The main cause of this bone reconstruction is the resorption of a significant proportion of the bone graft. And several clinical studies have reported graft resorption from 11 to 34% as at 46 months after surgery, like up to 42%, which is a quite substantial loss of the bone gain. The cortical block lamina screwed into the occlusal will act as a protection of the particulate graft by releasing it from tensions that the soft tissue exerts. And the particulate graft of the gap between the thin cortical bone and the crest would improve the revascularization of the area, which explains the lower resorption rate and a greater bone gain. And the results of the present review also showed higher values of bone gain in cortical tenting group. And the vertical augmentation techniques have been associated with high complication rates from 8% to 90%. And in the present systematic review, complication rates were of 15% for onlay grafts and 24.6% for cortical tenting technique. And actually, in the study, both techniques presented similar complications. And however, it should be mentioned that the cortical tenting techniques would need a greater learning curve because of difficult handling the graft, which must be cut into thin pieces and be frailer to manipulate. And different systematic reviews comparing various vertical bone augmentation procedures show that there is no evidence of any procedure which have a greater benefit with respect to implant failure. And a reported success and survival rate of implants with block grafting techniques is around 90%. And in the present study, high implant survival rates were reported in both of the groups. Implant success rate was poorly referenced in the study, and probably the reason being is that there is no uniform criteria for the definition of the implant success. And the lower peri-implant marginal bone loss in the cortical tenting techniques could be related to better vascularization of the particular graft, which means greater stability of long-term hard tissues. However, the lack of the randomized control trials comparing the both techniques make it difficult to have a definite conclusion about the study. And however, despite the limitations, both of the techniques mentioned in this article could offer a predictable way to reconstruct the atrophic alveolar ridge, though the cortical tendon techniques seems in this review seems to have a better bone gain and a lower surface resorption. Okay. And I'm presenting another similar article of the same author, which is to report the outcome of an intraoral onlay bone grafts on alveolar ridge augmentation, and it is also a systematic review. A localized or generalized bone grafts of the alveolar ridge, probably due to atrophy, periodontal disease, and trauma sequela, may render implant placement impossible or incorrect from a functional and aesthetic viewpoint. A variety of surgical procedures have been proposed to augment the local bone volume difference of the deficient sites, like the autogenous bone grafts, guided bone regeneration, and alveolar distraction osteogenesis. However, it is still controversial about which is the most reliable technique because there is no comparative studies. And 好像
有可能哦。可是过年到现在，
And the aim of the study is to compare the outcome in patients with localized alveolar bone ridge defects. And augmentation with intraoral autogenous bone grafts versus other techniques like guided bone regeneration, native bone extraction osteogenesis, or implants. And the complication related to augmentation procedure, graft success, implant survival, and radiographic implant modular bone loss were also reported. And this system review complies with the PRISMA guideline. And the exclusion criteria was case reports reviews, studies on sinus bone grafting, and studies only providing histological data, and bone defects after tumor ablation or related to congenital malformations, periodontal disease or trauma, or studies including both lateral and vertical augmentation procedures, but which did not separate the lateral and vertical parts. And the results. The electronic and hand searches yielded a total of 608 articles, and 453 studies were excluded after screening the titles, and 92 after reading the abstracts. Overall, 63 full articles were retrieved for a more detailed evaluation, but only 4 of them fulfilled the inclusion criteria for data extraction. The results are presented separately for the horizontal and the vertical augmentation procedures. For the horizontal augmentation, 4 studies were identified involving a total of 167 patients with 254 implants. And a total of 160 patients with 260 implants has a lateral ridge augmentation with intraoral block bone grafts. And the most frequent post-surgical complications included mucosal dehiscence, with or without the exposure of the membrane of the grafts. And in most of the cases, the membrane exposure could re-epithelialize itself without further trouble. And a temporary neural disturbance involves branches of the inferior alveolar nerve, especially when grafts were from the mandibular ramus. The implant survival for delayed implant placement varied from 97% to 100% with a mean follow-up period of 12 to 20 And for a simultaneous implant placement, which is only one study, it is reported to be 100% every 12 months of follow-up. And the success rates for delayed implants ranges from 97% to 100%. And the
What's the
success rate for doing a simultaneous implant was up to 89.5% at a 12-month follow-up. And the margin of peri-implant bone loss varied from 0.08 to 0.2 millimeter for delayed implants and 0.69 millimeter for simultaneous implants. And it seems that a delayed implant placement may be preferable comparing to the simultaneous placement. For vertical augmentation, 2 studies were reported, included 54 patients with 120 dental implants, and a total of 28 patients with 64 implants underwent vertical ridge augmentation with intraoral onlay block bone grafts, and all of them were delayed placement. And the bone resorption before the implant placement was significantly higher in the block bone graft group, and no significant difference were observed looking at the peri-implant bone resorption after implant placement. And none of the articles studies the soft tissue healing or the aesthetic outcomes. The implant survival varied from 95.6% after 1 year post-loading until 100% at 38 months post-op. And the success rate appeared from 91.1% after 1 year to 38 months and 89.5%. And the descriptive results of the studies that we collected suggested that there's a slightly lower success rate for implants placed with bone grafts compared with the other control groups. The discussion. And the data seems to demonstrate that the bone augmentation by intraoral onlay grafts can be considered a reliable surgical technique for obtaining sufficient bone volume for the placement of dental implants. However, the capacity of the bone grafts to restore original bone volume varies, and results reported in the literature are contradictory. And since the geometry of the defects and the residual bone differ in either the horizontal or vertical bone atrophy, and the studies were grouped separately accordingly. And according to the other reviews, the ridge expansion seems to have the highest implant survival and the success rate of the ridge augmentation. And the main criteria to consider the timing of the implants is that the residual bone volume to correct implant position and the bone density to achieve the stability of the implant. And in the present systematic review, the survival rates range from 97% to 100%. And the important part is that no differences were found in the survival rates of the implants placed with either the block bone grafts or guided bone regeneration. And the outcomes were similar to the implants that placed in native bone. The vertical augmentation is much more challenging, and multiple procedures like autogenous bone grafts, vertical guided bone regeneration, and alveolar distraction osteogenesis were proposed in previous literature. However, there is still considerable controversy about the most reliable technique due to there is no comparative studies comparing about these different techniques. And in order to be more conservative and to reduce the morbidity, the use of shorter implants in cases of reduced bone height in the posterior mandible has been encouraged. And in the present reviews, only 2 of the studies fulfilled the inclusion criteria. And the results from both studies suggested that there's a slightly lower success rate for the implants placed with the bone grafts comparing to distraction osteogenesis and shorter dental implants. And the disadvantages of the lateral or vertical bone grafting is the resorption rate of a significant proportion of the graft. And many of the studies recorded the resorption rate, and the suggestion by the author is that an oversized bone graft should be harvested in order to maintain a sufficient graft volume. And for vertical augmentations, there's an increased risk of graft exposure because when the soft tissue envelope is expanded vertically, the forces on the graft may lead to major resorption. So the assessment of the aesthetic parameters and the soft tissue stability should be put into consideration to identify long-term complications of hard and soft peri-implant tissues. The limitation of the studies is that there is no comparative design and randomized controlled studies according to comparing the two groups. And the author stated that the future research has to include control groups and develop a standardized criteria to define what is an definite implant success or failure for both simultaneous and delayed implant to have a rigorous evidence-based results. In this way, the data presented in this review simply considered indicative rather than conclusive. So the conclusion of this systematic review is that, first of all, the survival and success rates of implants placed in horizontally and vertically resolved edentulous ridges reconstructed with block bone grafts. The survival and success rates are similar to those of implants placed in native bone in either distracted sites or with guided bone regeneration. And more surgical challenges and morbidity arises looking at the vertical augmentations. And when doing the vertical augmentations, doing a shorter implants may be a feasible option.
Now, can you describe the first paper, the term? What is that? What is the cortical painting technique?
I think it is like to grab the alveolar bone in kind of a vertical way.
So what's the difference between vertical painting and onlay bone graft? This to me is the kind of onlay bone graft. But they compare the two types of bone graft, right?
Yes.
This is cortical painting.
This is cortical painting technique.
So what's the difference between cortical painting and onlay bone graft?
Like to my understanding, I think the cortical techniques is that you put the bone graft like a more thicker, like multiple layers, and the only bone graft appears like only one thin layer. Is that correct?
Well, in that, I would say that cortical changing technique consists of a thin laminate cortical block hanging over the particular tissue.
So there's a layer of cortical bone
to cover.
Oh, that's good.
So this layer of cortical bone is used to protect the underlying cancerous bone or particular material, which is called cortical painting.
Well, number one is that why you choose this technique or choose this tool particle, which we don't do regularly at all in our center, because this is most oral surgeons doing the augmentation of the reach to the ball and prosthesis or use. This is what the technique that we don't do regularly. Usually we just refer to oral surgeons. So it's good to understand the resorption, but it's not our experience that we can comment And we are inexperienced in that. So I use it.
Actually, I look at back to any kind of similar article regarding to our technique for probably the only bone grafting in. Probably we use it in orthodontic surgery or in some defect of the alveolar bone or medullary bone cases. But there is no similar article here. So I look for some like only bone grafting or for some bone resorption related article. That's why I choose. Yeah, of course, that we are doing for the dental implant, or we using the bone grafting like the only bone graft, or you use the cortical tendon technique. And we did not do this the surgery before. Yeah, so not related. The article can be found for previous experience. So that's why hard to present by our probably the international colleagues. So I think we can define our way to what is our so-called only graft in our center, or what is our experience using the bone grafting in maybe the bone defect cases, or what we need in any cases that we encounter in the orthodontic surgery. We have to choose the bone grafting.
We use bone graft very often during the OGS that after the board and there's a gap. I get more than 1 or 2 inches in between onlay inlay bone graft in between, so that it prevent the relapse of that. And the other is onlay is that when we advance the maxilla and there's a separation between the maxilla and the diploma. And so that gap, if that we have bone graft, we will onlay it. Interesting is that we don't know what happens 6 months after, or even 2 years after, 3 years after. Well, I'm a senior surgeon, so I know that the bone graft that onlay in the piriform area or that mud area with bone graft turn out to be 3-4 years after all the bone graft is melted out. So only screws and plates and many that is with bone back. So we do not have the literature talking about all this so-called long-term follow-up, but the senior surgeon in their article always mentioned about that. Bone graft, onlay bone graft, always result have percentage. And there's a phrase they mentioned about it that the onlay bone graft, especially in the piriform area or the diploma area, onlay, it will melt out just like ice cream in the long term or a lot. So the long term is more than 4, 3, 4, 5 years. That is that I want the fellows of listen to know that all this kind of long-term follow-up this kind of onlay bone graft will be solved so that you can choose another material like complication or metal. That's why that we use the hybrid graft for the crucial light. We type of place we don't do the 4-3, but we do the 4-1, but the gap on this diploma area. We use coverage instead of any type of bone, because I know that we know that bone will be solved eventually, but coverage will stay or will always stay. I think that in Dr. Shaw's group, the nose piriform area, they will augment the nose piriform area. What kind of material they use? Mostly metal.
The maple.
Yes, and they don't use the bone graft.
Yeah, no, not okay.
Material that metal. So somehow for this kind of onlay bone graft, surely we can correct our cases of onlay bone graft different and the different difficulties that the long-term follow-up, how the patient will come back, what type of injury that we can do. CT is the regular one, the painful ankle resection. And after the painful ankle resection, what happens to the resected mandible? Does it grow back? How much is that? How much muscle? And it's a lower. Already published a paper that we follow only for 6 cases, follow more than 5 years. So 5 years is a good time that we know it's bone graft. And that was just good observation of the function follow-up. We know that what happens to that. So the same as the bone graft, maybe that we can show something there. But I think this phenomenon has been known already. That's why that went from on this but for this, available to reach is totally different story. What I learned is that functionally, you can put bone graft and then put a screw on. You functionally, using that, the bone will maintain better. You don't research it too much. If there's no function, you will greatly result. That the TC go out the other switch will result. But if you put the screw and then you put one implant, you feel that the bone will not resolve. So bone is a kind of physiologically response. Just like if you have muscle here, pull it, bone will regrow. But if the atrophy muscle, bone will atrophy. So if bone is a dynamic, the same anywhere in the face. And on the bone graft, because the muscle is always compression, and muscle is not fluid, but it's compression, so it resolve. But in between, in the bone graft, the muscle power pushing of destruction is functioning, but you will stay, you will grow. So this is a review of the mechanism of bone survival and bone function. It's kind of active, but it's still not really active, but it's passively survive and passively functioning well and restore. So this is the phenomenon. So that's our real reaches, and we don't have any experience in that. So it's good to know, but not coming much about it. Yeah. For cosmetic augmentation, for these needs, so we can remain about that. You can use the bone or fat or metaphor, but in our center, it's a good way to handle the writing study. Maybe published mark is good, but it's not a scientific. Maybe metaphor is good one, but the risk of fine body reaction or injection, that graft is a good one, but the resorption definitely. I don't know whether it's predictable or not predictable. So with over grafts, I know that ground is they do augmentation for the asymmetry or for the necessary one. So onlay bone graft or onlay therefore or onlay fat graft. So what is the long-term result or the selection?
Onlay medical, I tried, but I have one patient end up with infection, and it's difficult to manage about that. Onlay bone graft definitely suffer from resorption, some degree of resorption. Inlay bone graft has better outcome. There's no resorption, and I think Professor Low has spacer, using spacer. Even that the bone will go through the space, but my thinking is inlay you can augment much more. I have one patient put on 1 centimeter of bone graft on the between the proximal and distal segment, and still survival. And Ying An has bad experience that she has 3 cases that not also infection. I think
in the positional bone graft.
yeah. But I think immobilization is a priority, so I always put two wires to fix the inlet photograph. Like Professor Chen told me that temporary fix with proximal distal segment